Welcome to my series of Healthcare Scene Google Plus Hangouts, where we sit down with top leaders in healthcare IT. We're excited today to sit down with Jonathan Teich, CMIO of Elsevier. Along with his work at Elsevier, Jonathan is an assistant professor of medicine at Harvard and a board-certified attending physician in emergency medicine at Brigham and Women's Hospital, where he has practiced since 1983. Jonathan's primary focus lies in the design of innovative information systems to directly improve clinical care, prevent adverse events, and streamline clinical workflows to address the most critical needs of the healthcare community. I'm pleased to have Dr. Teich here with me today.
John, great to sit down with you.
Great. So let's just start off. We're talking about the future of clinical decision support, but let's start this discussion with where are we at in clinical decision support today?
Well, we're at kind of a dichotomy. We are in a position where clinical decision support is clearly something which is shown to improve quality, improve safety, improve cost in a lot of settings. We're also in a setting where sometimes people have a hard time implementing it or do so in a way that doesn't get the buy-in or acceptance from their staff. So we are at a place where we have this wonderful tool which really should be helping out a great many people, and it is helping out many people, but it needs to be over one more hill in order to really get it to where it can be helping the entire country, the entire world, really doing all the things that we hoped it would.
Sure. So it's interesting you describe it as we have to get over one more hill. I like that description. So what's that hill? Where does CDS really need to go to get over the hill?
Well, CDS started out as people figuring out, trying to sort of simulate, expert doctors and doing that, and that kind of came and was the first wave and went away. Where CDS has been really most effective has been really providing information, providing knowledge that's really tuned to a particular situation. It's where, I have a question, I'm a doctor, I'm seeing a patient, there's something either I don't know and I wish I did that's pertinent, or there's something where I'm about to do something and I'm not quite sure if it's the best choice, or something I'm doing that might be an error. It's been very, very good at kind of affecting these one-shot situations. And I think when people realize CDS as the providing of the right information to someone just when they need it, just in the way they need it, I think it works very well.
Mm-hmm. I love the idea of context and how to provide the information in a context that makes sense. It sounds like that's really where it's going, right?
Yeah, I think so. This really is the work that I've been doing in many different walks of my life. The work I've done at Brigham and Women's, the work I've done in government, and certainly the work we're doing here at Elsevier is all about how do we really fine-tune, how do we finally discern what it is you're trying to do, what it is you're trying to know right now, and be able to give you the kind of information you need. So that's really a lot of work. It is some of it sounds very simple. Some of it requires a fair amount of advanced thought to look simple. The duck who looks very smooth on top of the water, but down below it's running. I think that's a lot of what really good CDS is doing, is being very smart and very intensive under the surface, so that we can give the nurses and doctors and patients the information they need in a very smooth and intuitive fashion on top.
That's interesting. I like that it takes as much processing power to understand when to give the information as it does to actually provide the information that's needed. Like you said, the duck underwater. Interesting. So, if we look at the future of medicine, could a doctor really be able to be a doctor in the future if they don't have these advanced, clinical decision support tools? Like, will they have to have this in order to practice medicine, or is that kind of a pipe dream and probably won't become a reality?
Well, I think this doctor thinks he needs to have it. Maybe. I don't think you could say that it's impossible to practice medicine without clinical decision support. But medicine is getting much, much more complex. And what do we know? We know that there are dozens of guidelines and new prescribed ways of doing things coming out every month. The way that we learn to do things in our typical apprenticeship medicine learning is not correct anymore. And so there's this real rush of new information, a fair amount of which that we're responsible for as publishers, I suppose. But there's a lot of new information, and even the stuff that we already knew, getting appropriate screening tests, putting people on aspirin after heart attacks. Most studies show that that only happens about half the time. So I think you can practice the fundamentals of medicine, but I think there are so many details and so many nuances that are hard to keep in your mind at the moment that they're needed. So I think it is those things that you really can't do without a little extra assistance.
Yeah, I mean, I guess it's true. If you even look at it, someone who's not medically trained can apply pressure to a bleed, right? So yeah, I mean, basic stuff, but maybe it's for the more advanced stuff that you really need it. Otherwise, the quality of the care you provide just won't be as good. So.
Absolutely. And with the government and the payers holding all of our collective feet to the fire financially to make sure that we do touch various quality metrics and that we don't commit certain kinds of safety things, and with them no longer being something that's going to be a positive for us in terms of reimbursement. So on the financial side, people are starting to realize that it's their bottom line that gets affected, as well as their desire to practice great medicine.
It's always better when you can tie it to financial. So yeah, let's talk about that though. I mean, really from the other perspective is, will clinical decision support improve the care we provide? And do you have some examples where it has improved care, or where there's a huge potential to really save lives? I mean, that's what we're talking about in healthcare, right?
Yeah, there are many examples. I can cite a few. There is work that we've done in the past shows that when people use order sets, when people use prescribed items that basically present to you appropriate doses of medications, for example, which is a pretty basic form. It's a very proactive form of decision support. It's not an alert. It's something which comes up at the start and says, before you make your choice, let's remind you what the best doses are and the best things to use. We've shown that when we do that, we actually reduce the accidental overdose given to patients by a factor of 5 to 10. So that's huge. We had found that something like 2% of all of the orders in our hospital were technically overdoses, and a few of those would cause real problems. With the ability to have that kind of knowledge in front of you before you do your action, that got reduced originally by a factor of 4, and then one of the nice things you can do with CDS is you can improve it. It went down to being improved by a factor of 10. So that's a good example.
That's good. So how about on the other end of things? Can clinical decision support avoid adverse events that normally wouldn't happen? It's one thing to improve care. It's another to avoid issues in care or adverse events.
Yeah, I mean, certainly it can, and this is where you have both an obvious benefit and a note of caution. So, a lot of people, when you think about clinical decision support, they say, "Oh, you're talking about allergy warnings. You're talking about drug interaction warnings." That's kind of some of the most. You're talking about alerts. That's some of the most recognizable things. I do A as a doctor or a nurse, and the computer says, "Wait a minute, based on the information that I've got here, A might be a dumb idea. Would you like to change it?" And then I can come back and say, either yes or no. So it's a pretty obvious thought process. If I make a mistake, this thing can catch me. I myself have been caught many times over the years by something saying, you might not want to do that. So it's a huge potential benefit. At the same time, this is where the other side of that dichotomy comes in. If you ask most people using clinical decision support what the big problem is, they'll say the problem is there's just too many alerts. There's just too many things coming at me, and I can't really process that. So how do I filter that? And that's where it comes back. How do I filter this out so that I'm not getting thousands and thousands of alerts? I want to get, my mind can handle about, 10 of these a day or something like that. So you have to prioritize. So it is, and if we say, oh, let's let every possible drug-drug interaction go through. This is research we've done with the government. Let's let every drug interaction go through and alert and let the doctor figure it out. If we do that, then what happens is that there are so many that we as doctors start ignoring them, and then we start ignoring the necessary ones also. So it is a great safety thing, but the safety gets diluted if we have too much coming at us. We have to recognize people's information capacity.
Right. So I think everyone can see some of the benefits. I think you're right. Everyone hears clinical decision support. You immediately go to allergy to drug interactions and drug to drug interactions, which no doubt is a form of clinical decision support. But isn't that kind of thinking too small? Like, I mean, shouldn't we be going well beyond that, or is that just where we're at? I mean, shouldn't we think bigger?
Absolutely, absolutely. There are in our book, Improving Outcomes with Clinical Decision Support, we outline 10 different kinds of clinical decision support, and it includes alerts, but it also includes sort of status displays. It includes analytics. It includes being able to have sort of intelligent advisors about various things. It includes info buttons and the kinds of ways that you bring important reference information into the situation. Wouldn't it be good if, when I'm about to treat a patient for esophageal varices, which is a bleeding condition that I happened to encounter recently, that someone could tell me right up front that, hey, there's new guidelines out on this, and people aren't using vasopressin anymore, they're using octreotide, and here's how you do that. And being able to have that kind of information coming at me, I can really have this be my companion at the point of care. This can be sort of what I sometimes call the smart doc hanging on my shoulder. This can be the person that says, don't forget some things that you don't really know and haven't even thought to ask about.
Interesting. So it's almost automating what many doctors do anyways at their association meetings and at their events. So that's interesting. So we have a number of questions from the audience, so I want to grab a couple of them. The first one comes from Mohammed Khalifa, and hopefully I don't slaughter his name, but he says, who should be the owners of the clinical decision support knowledge? Are they the health informaticians or the clinicians? And kind of related to that, should it be the hospital or should it be the HIS vendor that owns the knowledge base that you're doing? What are your thoughts?
Sure, and I see a couple good questions coming up here, and another one that's pertinent as well. Yeah, the knowledge, I think that knowledge should be widely open, but I think it's the presentation of it that needs to be carefully curated. Certainly, we don't want to have any company have a monopoly on this particular guideline or the use of this particular rule. If something is better care, then everyone should know that that's better care. That's sort of why we publish these things and make them out there. But on the other hand, clinical decision support is more than just the knowledge. It's about the delivery of the knowledge. So I think that it takes a reasonable amount of expertise to know how to deliver this, where in the clinical workflow to actually bring this information out for best effect, what kind of display, how to filter it out, as we talked about. So I think there is where you have, sort of specialists, and obviously I'm speaking from the perspective of a knowledge company. We think that a knowledge company is certainly full of specialists, and we do. We have dozens or hundreds of people that are processing evidence and doing things with that. We have many, many people who are specifically trained in how to deliver this stuff the right way. So I think that I think that the actual information belongs to everybody. I think that there's a lot of local rules which probably should be the responsibility of the clinicians. But I think when it comes to really delivering this in a way that people will respond to very well and use very well, I think that's an informatics process, and I think it belongs to informaticists in academics and for mass producing informaticists in the electronic health world.
Interesting. Yeah, another question from John Poikinen, and this is a question I was really interested in as well. It says, in a descriptive article in the New England Journal of Medicine in 2011, Evidence-Based Medicine in the EMR Era, that's the title of the article, it described complete info from the EHR, searching for like cases and outcomes to determine best courses of action. Will this ever become commonplace? And this is my question: is what's the path to get there with these EHR vendors so that this information is available in the EHR?
Well, this is great, and this is I noticed this out of the corner of my eye when I was talking about different kinds of decision support. This really speaks to a whole effort that's going on right now, which is usually under the rubric of the learning healthcare system, which is can't we take all this data we're collecting and use that to be a new source of research? I mean, why don't we, right now research on the best treatment for cholesterol, the best treatment for a heart attack comes from carefully developed studies. But we have millions and millions and millions of pieces of electronic health record data coming by reflecting the outcomes of all these cases. the concept of the learning healthcare system is that we should be able to take this stream of data and interpret it in ways that basically make studies. If in all these different hospitals there have been, several hundred cases of esophageal varices lately, why can't we take what people actually did, which is recorded, and how patients actually came out, which is recorded, and try and make correlations? In effect, this is using the EHR as the nonstop research database. So is it becoming commonplace? It is certainly an active effort. It's getting a lot of talk at ONC, the Office of the National Coordinator in Government. There's a lot of academic efforts around it. I think it will come more so. I think that it's going to take a little while before we understand exactly how to use it. It's a big data problem, and like any big data problem, it sounds exciting. There's a lot to be done, but it takes a lot of work to figure out exactly how to do it just right.
Interesting. When I heard John's question, I immediately thought the closest I've seen to exactly what he describes is modernizing medicine's EMA EHR. They actually do this, but they're kind of unique because they actually document with granular data across every provider the same granular data, so they've created somewhat of a standard. And then second, they also are very specialty specific, so they can do that across dermatologists where it makes sense. And so, that's the closest I've seen to it. It's interesting, though, you talk about kind of the research aspects of it, and we could grab that data and figure out what should we research based on the trends of what doctors are actually doing, which, if I understood you correctly. But how do we kind of drive that information to literally the point of care? It seems like the EMR and EHR vendors are somewhat resistant to really letting that happen.
I'm not sure if they're so much fundamentally resistant as they're busy.
Too busy with meaningful use.
Well, there is that. Yeah, I mean, we work at Elsevier. We work with many of the major vendors and talk with them a lot. And we have our own desired agenda. We want there to be more clinical decision support opportunities. We want to be able to find more ways that we can bring the knowledge that we have into the person's workflow in the EHR. But they, right now the meaningful use and other things have driven the vendors in a particular direction, which is the direction their customers have gone. So, between 2009 and 2012 or 13. Meaningful use and the money involved with it drove a lot of buying decisions. It certainly hugely increased the number of EHR systems we have and use in this country, which is a good thing. But at the same time, by prescribing specific things you had to do, it made people focus on those, and as a result, people aren't focusing on the other things. So it's just a matter of kind of trying to please your customer. I think that what we see with the vendors, and I will defend them, that they are very interested in providing new outlets for getting data out, and, if you will, inlets for letting the kind of knowledge, the kind of decision support tools we speak about come in. Vendors have different kinds of interfaces, different kinds of APIs, application interfaces, that allow you to inject orders, that allow you to inject certain kinds of rule-based things. So it's very variable. There is certainly no standard, and people do it very differently. But I think that they are interested in it, and I do think that it's been an issue that they've just been doing so many implementations of the basics that it's hard to get to that. But I think that's starting to change as meaningful use becomes a little bit more of a less of the crest of a wave and more of an ongoing thing.
Interesting. I think related to that, and Janine brings up an interesting comment about shouldn't those EHRs talk to each other? And it kind of goes back to who owns the data. You said everyone should own the data. So I think that's interesting. But will the EHRs release the data? Should it be an open source framework to be able to have that data, or should a company, a third-party company like Elsevier, provide that? Since EHR vendors are extremely focused on regulations, and as you say, they should be. How should that play out?
We didn't start out this industry with heavy duty standards, and people have been fighting very hard for decades to try and get those available. And there are some. You can connect various kinds of devices and so on. But yeah, there's everyone speaks about the same kind of things. If I want to say, is Mr. Jones a smoker? Well, there can be 50 different codes for what smoking is, interpreted different ways, used different ways. It is the answer to who owns the data. It's easy to say, well, the patient owns the data, but the question is, how do I sort of make that kind of manifest? How do I get that out there? So I think that there are certain things that can come out in standard fashion. It's not that hard to extract a medication list, for example. It's not that hard to extract a list of diagnoses. It can be harder to extract information about examination findings or about the results of an endoscopy. So it is. There's some things that are reasonably well done, but I think that it's by no means a perfect system. So the standards comes again with we need to have a very viable standard. We need to have some financial clout behind it, which is some of what happened with meaningful use, and we need to have people have the time and financial resources to go and convert. So it's an ongoing process. It is much better than it was 10 years ago.
Right, that's true. That's true. Yeah, I wrote an article recently. I said, imagine, 10 years ago we probably you couldn't even have dreamed that we could do what we can do today. And 10 years from now, there's going to be things that we can't dream of being able to do that, hopefully we'll be able to accomplish with clinical decision support.
Yeah, there's a lot of stuff that I use in my practice as an emergency doc. We have analytics that we didn't have access to before, which gives us a sense of how we are practicing in general. Where are we falling off the norms? Where are we kind of deviating and need to have corrections? So that kind of helps focus our attention. We have in the emergency department, where we care a lot about managing multiple patients at once, we have a very nice tracking display, which allows us to, by just looking at a few colors, we can see sort of which of my 18 patients actually needs my attention next. That wasn't possible, 10 years ago. So there's a lot of things that have advanced. I think one thing that's I would make a soapbox for, John, is that there has not really been a good place for people with successful CDS to share it easily with other people with successful CDS. Right now, if I do something well at Brigham and Women's, the guys across the street have to build it themselves, and so do the 6,000 other hospitals in this country. So what we don't have so much is a framework where people can share their intervention, share their experience with them. Right now, it's kind of catch as catch can, anecdotal stories. So there's some work afoot right now to try and be able to share innovations in that way.
Yeah, that's an excellent point. Yeah, there really isn't the sharing. It's unfortunate. And the media, and I guess I can lump myself in there somewhat. It's easier to report the failures than the successes. So
yeah,
we probably don't help. And in fact, I think related to that, there's another question I thought is interesting is, a lot of doctors look at clinical decision support and say, man, you're just making more work for me. Does that play out in your experience using clinical decision support, and should it be that way?
It should not, and I think that when well done, it does not. I think that this is the whole issue when I said that you need some expertise in designing these things. Good CDS is, like I say, whispering in your shoulder, standing on your shoulder, whispering in your ear. I'll get my body parts correct.
You can whisper in your shoulder too.
That's right. Could be whispering in my shoulder. Good CDS is kind of a periodic whispering in your ear to remind you of something. Bringing out knowledge that you had before, and when well done, it is right there in front of you. It is on the screen you're looking at, or at most one click away. It is obvious, so as I'm looking at my display of this current patient's record, it can say on the side, there's one important thing you should know: this patient's diabetes is not very well managed. Click here for some orders or some care plan elements to do so. So being able to, again, select and advise and come in the right path really reduces work. The other piece that I really want to get across is that it's not just about doctors, right? Reducing work also means distributing work. And there is CDS that's applicable to physicians. There's CDS applicable to nurses and to pharmacists and to dietitians, and don't forget the patient and their family. And I think when you take a look at a particular action you want to achieve, there's 5 or 6 places, not just one, where that action can be presented to you, where that knowledge can be presented. And if you distribute it across different workflows and across different people, if you say, well, for the nurse, it gets involved in your care plan document. For the pharmacist, it gets involved in the drug choice process. When you do that, you really distribute the work out, so you're not suddenly taking everybody's work and giving it to the doctor.
Excellent. Well, Mohammed Khalifa has another question that I think is worth addressing and probably could be a Google Hangout of its own. But he says, what do you think about the legal side of compliance with CDS advice? Can we expect that there will be some kind of accountability or liability in case of overriding CDS alerts or reminders? So how about the legal implications?
There are many. It probably comes up in a discussion at HIMSS almost every year, I think. And I would.
Right? We're worried about the medical liability, right?
Sure. And if you read Health Affairs, I'd direct you to any number of articles in Health Affairs about this. But I think it comes down to this. The most important thing to remember is that we can demonstrate that people using CDS make fewer mistakes than people not using CDS. Mm-hmm. So we'll talk in a second about whether going with it or not going with it. But what you get sued for is doing something wrong that you probably shouldn't have ought to had to do, right? Mm-hmm. And if you have CDS, overall, you're going to make a lot fewer of those. And in fact, when we first put some of this stuff in my hospital, we actually got about a 10 to 12% rebate from our insurers because they found that our adverse events were going down to a substantial degree. So I think the answer is that more information directed to helping care is going to help you do better care, and that's where you're going to save on liability. Do you find that there's going to be increased liability because of following an alert or not following an alert? I think it's certainly easy for an attorney in a trial to bring out that this thing was telling you to do this and you didn't. But the fact is, if you see it and you have a chance to think about it, I think that's a lot better than not seeing it all.
Mm-hmm. Interesting. I love the case of clinical decision support and EMR should make you a better doctor and should lower your liability. Are we there yet with all of it? Maybe, maybe not. I think insurers are a little mixed on the results. But the idea of looking off an alert, that provides other legal liability questions. It's interesting.
Yep, absolutely.
And no doubt we'll find a lot of case law over the next few years on it, and then we'll learn more about what they expect, right? Yeah.
Well, there have been certainly CDS has been with us for 20 years or more, and it comes up periodically. It typically comes out as, well, what you're judged on in a trial is whether you did something right or wrong. And while you can make a little dramatic statement about whether this thing was there in front of you, the fact is that CDS is not giving you new arcane knowledge from a world-class expert. CDS is reminding you of stuff you probably already learned.
Sure. Yep. No doubt. So, final thoughts as we're at the end of our time, but what should everyone know about clinical decision support that we haven't talked about already?
Well, I think number one, it is very, very helpful to both your care and your cost when well done. Number two, I think that people should realize that alerts are not all there is to CDS, and that being able to have other things, like I mentioned, analytics, being able to have informational things that bring up relevant pieces of guidelines that help you make a decision. When I'm deciding whether I should be doing this CT scan or an MR for a particular thing, it's nice to have a little paragraph of carefully curated knowledge coming at me that says, hey, this is what research says is the right thing to do. So look for other ways of doing it, and look for ways of doing it across the whole team. That it happens. CDS often comes in packages, and I think it usually takes more than one individual intervention to really make a difference. But that will get us from what we have now, which is CDS, which is very effective at kind of doing one-shot critiques, and move us to an era where CDS is really helping us to do better planning, better overall care, and really affect the quality side of the house.
Excellent. I appreciate you spending some time with us today, and we'll certainly have you back.
Sure, John. It was great to talk with you, and I look forward to doing this again.
All right. Thanks.